in West Philadelphia, born and raised on the playgrounds where I spent most of my days. Chilling outside, relaxing, all cool, out shooting some b-ball. I thought I was cool when a couple of guys was up to no good. Started making trouble in my neighborhood. I got in one little fight. My mom got scared and said, rising up, back on the street. I did my time and took my chances. Went the distance, now I'm back on my feet. Just a man in his will to survive. So many times it happens too fast. You trade your passion for glory. Don't lose your grip on the dreams of the past. You must fight just to keep them alive.
right, the Finance Committee will please come to order. Good morning, everyone. Thank you for being here. Good morning, Dr. Schrader. Any citizens would like to address the committee this morning? None signed in. All right, we'll move to item 3, and I'll entertain a motion for approval of the minutes from the February 22nd meeting. We have a motion by Dr. Weber, a second by Ms. Debose. Any questions? All in favor, please say aye. Aye. Opposed? Motion passes. Item 4, CFO report. Ms. Clark.
Good morning. I'm going to take some time this morning in my CFO report to follow up on an item that you had some questions on last Finance Committee.
Questions about a member who's not here?
What?
Questions about a member who's not here?
It could be that, yes.
We could say should
We could, so I'll keep it short and y'all can ask me questions as I go through it. But several of you, I think, had some questions as we were trying to ask for your approval on eScan last month. The hospital, I kind of want to back you up a little bit before and how we get to the self-pay category. There's, if you think about the pie chart that shows our payer mix, there is a large part of our patient population that comes in with no insurance. There's also a large population that comes in with commercial. And if you have commercial insurance or any insurance, grant, Medicare, Medicaid, the JPS staff actually do all of the collection work in-house because those are very complex accounts. We have our own payer contracts that we work with. And at the end of that collection process from the insurer, which could take 30, 60 days on average, the insurance company will also notify us of what exactly the patient responsibility from that commercial account will be, whether it's a copay, a deductible, or a co-insurance amount. So once those patients, the insured patients, make it through, they may also end up in this process for their $1,000 deductible or their $250 copay for an inpatient stay. So I just kind of wanted to set the stage about how you enter this flow before I get started on who is actually helping us. So self-pay, there are a lot of accounts. They're very difficult to collect on. They take a lot of time. And I'm going to kind of go through this and try to explain to you some of the advantages and why it's more cost-effective for us to outsource the way that we do. So you have, if you look at the vendors on the right-hand side of the page, you have approved 8 of these vendors in the last 12 months. So if you think about how many you've seen, you have seen a lot. We've only got one that we're probably going to go out for RFP in the next quarter or two. But all of the rest of these have been approved very recently, probably for a 2 or a 3-year contract. So I just wanted to kind of put that in context as well. So on day 1, if you happen to be an uninsured inpatient in our facility, Change Healthcare or MedData will visit you, have a face-to-face application process, trying to see if you qualify for Medicaid, Medicare, and their specialty is really on the more complex cases with disability and SSI. So that happens when you're inpatient. There are a few outpatient accounts for the higher dollar services based on the DRG, and we may make a phone call if you're an outpatient. On day one, we start to drop statements, and those statements are printed by letter logic. If you think about the volume of statements that we have and just the sheer machinery that it takes, that is why we outsource. They do the printing, the envelopes, the stuffing, as well as the postage. Hope that battery doesn't go out. So we drop one statement on day one. 30 days later, we drop another statement. Now, during this process, we're hoping that the patient, if they did have insurance, will call back and give us that information, and then they'll go into the commercial collection process. However, some patients don't call us even though they are insured, either through Medicare, Medicaid, or some commercial coverage. And at day 45, we will send all of these files to our vendor eScan. And this is insurance discovery. They're not qualifying patients for insurance. This is actually, if you have them, eScan has a real-time connection with the major insurers as well as Medicare and Medicaid, and they will go out and see if that patient is on any of those lists. And they may return us information which does create an insured account, and those as well will go back over to the commercial collection process. If after, yes, sir.
In the first 45 days and the first day 1 to 60, we don't know if they have insurance. You said you're counting on the patient to call in and say whether they do, so we don't know that yet.
Correct. There's still no insurance information at the time of registration, and they have not called to confirm. Now, you know, we may Change Healthcare or MedData may have found those coverages for that patient, and if at any time, usually within a day, they will let us know that they found coverage, and then they will be billed by the JPS staff for Medicare or Medicaid. So we're 60 days into the statements dropping. At this point in time, the patients have just received 2 statements. At day 61, we start to, with the Durima and Parallon's help, and where you see 2 vendors, these are actually done on an alpha split. But with the Durima and Parallon's help, we start to make outbound phone calls to patients to remind them that this bill has been outstanding, and they are at any point in time able to make payment arrangements. And the process that Durima and Parallon are using use very sophisticated phone call trees. They have options for incoming, inbound phone calls. So this is just an extension of the JPS business office to try to actually start a second method of communication with these patients. Now, after 4 months, if we have not received any information or response from these patients, we do consider an account to be in bad debt status, which means that people are not responding. So we transfer those accounts to Data Search and FMA Alliance, again an alpha split. These companies are more aggressively collecting the account, more phone calls, and just to try to get the patients to respond. Now, they actually have these accounts for 5 months. If after 5 months we do not receive any information for a smaller account, they are just written off and put into a permanent bad debt status. If it's a larger account, we will use Data Search for an additional year on the larger accounts and try to collect on these.
What's a small account?
We measure that by $1,500 or less.
Thank you.
There may be some exceptions to that, but that's kind of the cutoff. And as you progress through this chart, obviously they become harder and harder to collect. But we do have recoveries from all of these vendors.
Any questions for Sharon on this? Yes, Dr. Ziegler.
We have one. I mean, what are we billing the patient? Because there's a huge difference between a self-pay and an insured patient. For example, a gallbladder. I mean, self-pay we charge them $2,000, but if they have Medicare, you're only paying about a quarter of that. So what exactly are we billing? That's one question I've had is what exactly are we billing them as a self-pay? And I mean, that's going to be a huge bill.
So the self-pay accounts, before billing, there's actually a self-pay discount that is taken before we send the bill out. Now, when the patients call back, we also try to accommodate payment plans. We also try to look at their current financial situation. We try to get them into the connection program if they're eligible at that point in time. So this is a very long process. And Dr. Ziegler, I can't turn around and look at you and speak into the mic.
I can hear you.
But so we are constantly trying to find payment sources. These efforts, the first thing we need the patient to do is return our call or to call us with some information. So there are other opportunities to get these patients covered, but we do have to talk with them during this process.
It's a peanut plan.
A payment plan.
That's when you get paid.
That's our plan, yes.
I was not pronunciating, I'm sorry.
We're in a cookie plan.
Sharon,
Yes, sir.
let me go to the Dreamer. That collection step, that's the soft approach.
It is. That is just an outbound call to say, you know, not sure if you've been receiving your statements. And again, that lasts for 2 months. So we've got lots of opportunity.
And these are trained, I'm sorry to interrupt, these are trained callers. I mean, people that do this all the time, and they kind of know that there are scripts and there are certain ways of dealing
Correct.
with responses. I mean, I've seen it before, and it's an interesting science behind it.
It is
So
a
they've been
very
calling you?
specific.
About you.
It is a very specific skill set that these people have that are making these outbound calls.
Right. I'm sorry to interrupt.
But yes,
you.
day 61 to 120 is the soft approach. If after we have not heard back from the patient after 4 months, that's when we start the bad debt collection process.
I'd like to sit down and talk to you about that outside of this. Okay.
You bet.
When you start going down the,
Can you turn your mic on? Thank you.
I'm not sure it's going to help. When you start going to the bad debt, is that still a percentage of collection, or they adding additional collection fee on top of that? I'm just looking from the patient point of view.
It is a percent of collections that we do not pay these companies until they actually collect on an account. So
the actual amount, not additional collection fee tagged onto it for
correct.
that purpose.
Yes, they
Okay.
are paid as a percent of collection.
Okay. Do you know, do you know what the percentage within the day one eligibility that has Medicare in it from these two vendors, even though they're doing Medicaid?
Say again.
From what is the percentage of conversion from self-pay to Medicare, even though they're focused on Medicaid?
Right.
We can get that for you. I did not bring that in my notes today.
Okay.
But you're right, that the primary focus is Medicaid for change and MedData. If they happen to find any other eligibility, they will go ahead and turn that over to us immediately so that we can start to bill the insurance company.
Oh, I see. I thought we allowed them to go ahead and collect on Medicare also as well, according to the contract for change in metadata.
Correct, they do. They may turn accounts over with Medicare or Medicaid eligibility, but after they identify it, they give us that information, and it goes through our commercial process.
So they reconcile it.
Yes, the JPS employee group will actually collect on that.
So they are assisting with end-stage renal disease, new onsets, as well as QMB.
Right.
It's the Medicaid to Medicare.
You talk about ESRD,
Right, through
I think.
right.
I'm sorry.
You might explain that.
I have another question, because is 60 days enough? Because if you're trying to qualify them for SSI, it will take 90 to sometimes 180 days or more to qualify
That's
for
a very
SSI.
good nuance that I did not try to cover in this short presentation. Yes, when they're looking at the Medicaid SSI and disability process, that could take up to 6 months. And if an application has been worked there at the beginning, then that will qualify for their
There's a
reimbursement.
presumption that they'll be approved, it's just a matter of time, so we'll put them to the side.
Yes, they would go into a Medicaid pending status, but a lot of the applications that they go through don't qualify. They can tell they don't qualify right away, and those folks would drop into that day 1 through 60 print statement process.
That was the reason why I asked to see.
Yeah, and I tried to kind of offset 2 of those boxes to show, there's a day process that starts to click through some of these vendors, but we also have 2 eligibility processes, 1 eligibility and 1 discovery process, where we are doing our best to find if these patients are insured or can get eligible.
Here's the question I have for you, right? Is it a better way for us to have, because you do an alpha split between Change Healthcare and Medidata, and after that 60 days, is it better for them to switch role to see if they can still picking up the other vendor didn't pick up, to double check to see who has a better process?
We could try to look through that, but I believe that the companies have kind of a proprietary, once they do the application process, that would make it really confusing of, okay, whose account would it really be?
I'm not concerned about that one. I'm more concerned about is that do they have enough foot on the ground, right? Because if you still in-house and you send the patient, what do you call it?
The advocate?
If they in-house, then you're doing them a favor, because they don't know if the diagnosis come out to be other stuff that can be life-threatening and all that stuff. But the moment they leave the facility, it becomes a collection call, and they're not going to be helpful. So that's why I was trying to see if you swap those, then you can see the return rate that could be higher than you expected, because they just don't have enough people walking the floor.
They typically hang on to those accounts post-discharge for the coding, and they'll continue to work those inpatient accounts for a period of time.
We do.
I don't think you catch what I'm saying, because if they're not in-house, they're already discharged. It's almost impossible for you to make a phone call to them, for them to return your phone call. So if you check to see how many of those accounts, the status is patient, waiting for patient to answer, they don't pick up, those are the ones that they miss the opportunity because they don't have enough staff in-house to walk the floor for us.
So we do review their work, and we can review it on a daily basis. I know I look at some weekly reports that are summarized, but the goal is for any inpatient in the bed to actually have that application process or that conversation completed. We can come back with if any inpatients are routinely missed, and we'll challenge them on the staffing if in fact we have not had our inpatient self-pay population completed before discharge. Is that more your question?
Because I think we may want to develop that. That way you can tell if they cherry pick the account. Because if it's a smaller account, who cares? We'll call them later because it's not the recovery is not that much. So it takes that type of game playing out of the equation.
Okay. We will start to review and see which inpatients may have been missed. If it's a short length of stay, they may have, but the goal is for every patient to be covered before discharge for if they're in inpatient status.
Right. Because the challenge is that I think under David, he moved it to the point where I'm not sure you guys still practice the same process, if I'm not mistaken. Our people's trying to register them for JPS connection first to save on the collection side. But if you did that, then there's not enough time for them to catch that patient while they're in the house, because by the time you turn around and give it to them, they're already discharged.
They actually have a high percentage of interview rate, so they, on a daily basis, we get their percentage of how many are screened, and it's in the high 90s of all the inpatients per inventory. But we can get you all the stats.
And then maybe when you come back later on, the letter logic to see what is the percentage of payment
During the first 60 days, what payments are returned, just
to see if they in
Sure.
the 15 or more percentage. If it's lower than that, then maybe that's a concern.
Absolutely, and next month we'll probably have some more news about some enhancements with letter logic.
And during those first 60 days, those statements are directing the patients to call our call center back. So part of Katie's team is really focusing on all of those inbound calls generated from day 1 through 60.
I'm sorry.
Yes, sir. Oh, yes, sir.
When does the patient find out how much they owe? Is it when they receive that first statement?
Mm-hmm. Yes. That would be the first notification that we give them, and that's kind of at the beginning when I talked about there's a couple of different ways you can end up in this self-pay flow. It may be a month or two after you're discharged. If I came into the hospital, my employees, our own department, would begin to bill my account with Cigna. We could get that information depending on how long it takes for that bill to process with Cigna, as long as there's no issues. It could be within 2 to 3 weeks, or it might be 60 days. Once our staff post the explanation of benefits and Cigna has said, okay, Ms. Clark, you owe, $250 for that treatment, that $250 will begin. I will start to get a letter and say your copay, your insurance is paid, and this is what Cigna has notified as your responsibility.
Okay. Does the patient, is the patient at any point made aware that they could receive a letter?
A bill that a patient
prior to discharge?
So there's a lot of processes along the way that as they're registered, they're notified that not only will you potentially receive a hospital bill, but you may receive other bills for physicians. Sometimes you get an external lab fee. So it's a long form, and most people have heard it many times. So it is done, and they actually sign a disclosure that they understand. Now, whether the patient actually sits there and reads through that disclosure, or if they're already familiar with it, But yes, you know, even when you go to your doctor's office, you sign a financial responsibility form that if this is indeed a non-covered service, even though I may have commercial insurance, you know, it may be something that is not included in my benefit, and that would immediately become a self-pay, and I would be financially responsible for that. Are there any other questions?
Make sure I understand this. Is it fair to say that at no point,
They know they can pay or they can't pay when they get
at no point, if
That's
they
what I'm
say,
saying.
well, I don't know if I've got insurance because maybe they live with a relative or something, at no point does anybody get treated differently because they can't pay, and at no point do we say, look, you have to cooperate with us by at least giving us your information so we can put you in our system properly, or there's some penalty. What impetus is there, or motivation, or carrot or stick does the system have to say, no, you have to do what you can do? Is there one?
We do upon, if it's a scheduled procedure, we will reach out to the patient and try to pre-authorize their insurance if there's already an amount, and we will try to collect their copay or deductible before let them know that they owe a copay or deductible if they're insured. If they're not insured, again, scheduled patients, we have the capability to try to communicate with them and try to set up some payment arrangements before they come. If they're already here and they just don't have their insurance card, then we go ahead and see that patient. A lot of our admissions come in through the emergency department, and you may or may not have your insurance card at that point in time. So, I was in a situation where we did not have an insurance card, and we registered, I signed the financial disclosure form, and, when I got to a point that I could give them my insurance, I actually called back, and because I did not want to wait and receive that first bill to say this is self-pay. So I think the main carrot for people to go ahead and notify us that they do have insurance is that we're going to begin processing that on day one. Insurers also have filing deadlines. So a lot of the commercial plans, you cannot file 60 or 90 days past date of service. That will become a non-covered benefit for you. So, if you do have insurance, and a lot of what eScan finds for us is patients who may have just assumed that they're no longer have Medicare or Medicaid coverage, or they just don't understand that they are still covered under a plan, or they have not called back in to say, I have this coverage. And that's why we do it at 45 days, so that we still have the ability to drop that claim and get that in their system so that we don't miss the filing deadline for an insured patient.
Let me ask you on the, go ahead, Dr. Ziegler first.
Typically, though, the physician's called and says they don't have money to pay right now, and then depending on what their need is, obviously this could be a cancer, we really need to jump on this, then we'll make arrangements.
Mm-hmm.
Something purely elective that this really is not important right now, then we'll wait for some financial arrangements. But depending on what they've got, we do scrutinize. This could be a real bad problem. We need to jump on this, regardless of their ability to pay or not.
On your self-pay, do you drop a zero balance claim into the Medicaid system?
Say again?
Do we drop a $0 claim into the system while that we're waiting for get qualification?
Yes, we do pseudo claims while they're waiting for disability. So prior to the year deadline, or whatever deadline, the companies will notify us. We send a sort of false claim, and then so that we could protect the filing deadline.
That's good.
What it is that you have 91 days for Medicaid. If you drop a zero claim, you have another 180 days extra
To
on top
appeal.
of that.
To resolve the.
Resolve it, so
That's
you
awesome.
don't lose on timely billing.
And Medicare CPR.
This number will change. All right, well, thank you very much. Move to item 5A, February financial report.
So for February, we had a strong inpatient month. Our admissions were up by about 8%, and our case mix was higher, which created a bit of a negative impact on our length of stay at the bottom right. We were favorable in many of our outpatient statistics, looking at emergency department. Although we were down from last month, which was an extremely busy month, we still saw an average of 336 patients in the emergency department. For urgent care, we actually saw an additional 159 patients a day there, even though you can see that they too are down from their all-time high last month. Looking at the year-to-date activity for the emergency department and the urgent care, we have seen almost 500 patients a day for the first 5 months of the year, 495 patients a day. So there's still a lot of traffic coming in through those urgent settings. On the right-hand side of the page, again, I've separated the primary care clinic visits and the specialty clinic visits. They were both favorable to budget by 5% and 2% respectively. And observation cases were slightly under budget this month. Our invasive lab cases on the right top are actually high. We saw 650 patients through that service. Our surgeries at the bottom of the page, both the inpatient and the outpatient surgeries are down. Inpatient was down by about 11%. Outpatient was by about 7%.
Because that's become a trend, I mean, every month. So what's the take on why that's not where it should be?
So, you know, we talked last month about the transition for the surgery group and kind of looking at scheduling. We are focused on making sure that we're doing what we can. But, you know, it's kind of hard to trend, but if you look at the light yellow, like right, you know, on these sides, we're not, that July was a little bit of a anomaly, but we have been fairly close. And then if you remember, November, December was really a lot of transition months. And I know that we are also trying to get some of the positions filled permanently as well.
Are they filled now?
Excuse me?
All of the surgery service filled now?
I'm not sure on that. Is Diana here? The question was, are all of the surgery positions filled currently?
We're covering with locums where we don't have permanent members. We have several physicians joining us this summer as their fellowship training finishes. So positions have been hired and filled, but now we just need to get them here.
Okay.
So all the positions are filled or not?
The surgery, everything is being covered with either locums or folks who
So if locums are covering it, then staffing is not the reason for the down.
Right.
So what's the reason for the down? If it's not staffing, if it's not surgeons, why are we down? Because this is like the 7th month that we're way below budget.
Correct. Yeah. So I will, oh, here comes Wanda. Thank you. I would have had to get back with you on that.
Wanda's here, though.
Wanda's here.
Some of the changes that we've seen is when Dr. Leovano left and the new urology group came in, they practice very differently. So we've seen a significant decrease in our our urology cases based on they don't take everything to the OR, and there's the way they handle different things. So that has been a significant decrease. We also have a neurosurgeon that left that we've not replaced. So we've seen some decreases there as well. So those probably are the two biggest things. And then maybe a little bit with the transition of surgery, but those are the two biggest things that we've seen changes in our surgery volumes.
Do we feel good still about our administrative process of making sure that the suites are turned and that we're scheduling well? Because I know we made huge progress in that in the past. And
we're still doing fine there.
That was good. So now it's just a matter of adjusting to new, because that sounds to me like a permanent adjustment.
It is.
If you've got a group that's not using the suites, then that's not
But,
something we're going to see.
we're filling those rooms with other things. They may be different things, but they're not, but they had to gear up to, so I think we'll see those pick back up as we go forward. As Dr. Leovano left and they transitioned in, we had a little bit of a lull there that took us down, and then now they're ramping back up. But
So it's not something that you would looking at budget 19, it's not something that you would say we need to adjust our expectations down.
no, I think we'll fill those rooms back up very soon.
Okay,
So,
thanks, Wanda.
Any other
One thing
questions?
that I'll make sure to point out when we get to the financial statements is there's some significant supply underages because of these lower surgical volumes as well. So we have lost some revenue, but there's also a really large expense that's not there anymore.
There is one other little group, and I don't know how big the number is, but there's, especially in vascular surgery, there's a big trend to doing endovascular work in the invasive lab and not in the operating room. So I expect to see the invasive lab start to tick up, and I think it has. But I really don't know how many patients that really is. But I think Wanda's too, urology and whatnot, it'll get back up.
And Trent, for projection into the 19 budget, we will really be looking at utilization trends and what's going, what's not making it to the OR that historically had. Obviously, it's already kind of in our actual trend, but we work with Wanda and the surgical, we look by surgeon. Is there any changes that we feel like might be coming because of changes in utilization or practice pattern?
Well, that's really my whole point. Is to the extent that we are seeing trends that become predictable trends, then those have impact on future capital planning. And to the extent that we need to illustrate that in terms of expectations for the bond or for facility needs, then the more we integrate those things faster, the better.
Yes.
Because we're going to be looking for places to cut, I'm sure.
Inefficiencies.
So it's just, as we see those things, I mean, that transition into capital planning becomes really important. So, but it sounds like this is not a circumstance that would impact that at this point. So.
Thank you, Wanda.
Anything else for me?
In psychiatric services, we did have a strong inpatient month. Our outpatient, both the emergency visits, clinics, and hospitalization days were partial PHP were all slightly down. The bottom two charts were about 10% under budget. And then for the financial metrics, we are kind of at a high point for the year most likely. right? And in February, we are at 274 days cash on hand. If you recall, in January and February is when we received the majority of our tax payments from property taxes. And our accounts receivable days on the right-hand top have remained constant at about 48 days.
And Sharon, just let me ask about that. I'm surprised that the blue bar in this year is less than the yellow bar last year.
On the AR days?
Days cash on hand, because to the extent that we're talking about the inflow of monies from taxes, which is the cause for the spike,
yes,
then you would think that as valuations and overall revenues from taxes increase, that the days cash on hand would increase proportionally. And it doesn't, and I'm curious about that.
So we have laid out some cash recently for land acquisitions and for other items. And each day is worth a little over $2 million.
Okay.
So you have seen a ratcheting down somewhat. Also, you know, we're trying to, the patterns of the payments from the state also have a large impact of how the days cash on hand is impacted.
So that brings up a question then. When we calculate days cash on hand, do we include things like the facility fund in that days cash on hand number?
Yeah, so, you know, we had a conversation at this committee a few months ago on the days cash on hand. So this does include the JPS Future Fund. What I probably need to start doing is pulling that fund out of the available days cash on hand that we look at, because I think most people interpret this calculation as
unencumbered.
The unencumbered or undesignated cash. This graph is calculated like S&P or Moody's would calculate our fund. So it includes all those board designated dollars.
Might do two. Do one with it and one without it.
We could do that. Yeah, we've got room on the page, so we can do you know, available cash as well as the S&P calculation that you would typically see if you went out and tried to compare us to others.
Yeah, because to the extent that, and you're right, there's two different ways of looking at this. There's the S&P look when it comes to bond rating, but then there is days cash on hand as it relates to available funds necessary relative to our operating
and
costs.
The board's intention is for those funds.
So that piece of it becomes, and you know, Ralph knows, we think like this in government. We're thinking about, okay, how many days cash on hand really relates to how many operating days of service I have put in the bank that I have not encumbered relative to my future obligations. So I think it would help if we saw that, you know, superimposed with S&P's calculation. I think it gives us a better look, because when I think about days cash on hand, I don't think about the future fund.
You already think that's set aside and out of the calculation.
That's spent for all intents and purposes.
Okay, well, we'll add that graph for next month.
Thank you.
And is it not also true that a day of cash last year is a different number than a day of cash this year?
It is when you get down to the detail calculation. It hasn't changed significantly, but our cost structure, because of inflation of salaries, medical supplies, pharmaceuticals, that day's number, my expectation is each year it would cost a little bit more to run the facility.
Yeah, when we're looking at little stripes that are right next to each other and they're maybe 5% difference, and that 5% difference matters, right?
It does.
Yeah.
Yes.
Thank you.
Okay. Our FTEs per APD are favorable year to date. Our overall budget is to end the year at 5.8 FTEs per APD, and we're at 5.68 now. We do pay about 5,600 full-time equivalents currently. The JPS connection enrollment stayed really flat this month. We didn't see any growth. We actually saw about a 0.5% decline. And hopefully over the next few months, we'll be able to recover from the re-enrollment that occurred in January. So for the hospital's income statement for the month, Again, from a net patient service revenue standpoint, we were about 3% favorable to budget. A lot of that was the inpatient volume, but outpatient volumes were actually about 3% under in total for all services. We did have a favorable payer mix this month, which helped us beat our budget for that one line item. Our other operating revenue is under slightly, mainly because of our pharmaceutical assistance program. There's also an offsetting underage in the supply expense, so that's kind of a wash on the bottom line. You'll notice that salaries are over budget, mainly due to the inpatient volume that we experienced. And our benefits line item is over, so I've talked about salaries. Our benefits line item is over as well due to some large claims with our employee health insurance this month. Again, yes. We've had several of those. October was unfortunate. That was our first month for our new financial year, and October was over as well. So we are monitoring that closely. Our purchase service is over budget. Most of that is due to the unwinding of TCICC and how we offloaded contracts to make the IGT payments. So you're seeing a bit higher expense in purchase service. And supplies, I've already mentioned, $1.1 million under in supplies. A lot of that is due to implants and some patient chargeable items. A lot of that's related to that surgical underage. We'd budgeted earlier in the year to bring back a portion of our lab and had budgeted some supplies in that line item, but it has continued to be outsourced. So that's just a delay there, creating that savings. And we also have some underages in IT purchases and software. So when you add it all together, for the month, we lost $1.1 million compared to about a $200,000 budgeted loss. And year to date, the income from operations is $181,000 compared to about a $2.1 million budget. For a claim, they continue to have a few open positions, and they are approximately 6% under budget. They had 67,660 encounters this month, so still a lot of volume going through a claim, even with those unfilled positions. And then I'll point out our net operating expense per encounter, even though it was slightly higher than budget this month, year to date, we are still about 4% favorable. For a claim on their income statement, most of these variances are simply related to those open positions. We have encounters 6% under. We also had a slightly unfavorable payer mix here. If you drop down to the purchase service, the salaries are under, and these purchase services are under as well. A lot of that has to do with, we had budgeted to actually have these physicians contracted, and they are now employed. So that's just a shift in the line item. But overall, they had a good month compared to budget, $807,000 loss compared to a planned loss of $829,000. And year to date, they are about $250,000 ahead of budget.
Yes, sir.
We had a 2.5-hour meeting.
Can you turn your mic on?
With Commissioner Nguyen not too long ago. Warren was there, DT was there, Sharon was there, Robert was there. That I thought was very, very productive in going over the budget for a claim. it helped me, oh, Jenny was there as well. And I thought it was good. It was, I hope to help explain some things to Commissioner Nguyen. I think it did, based on the comments that he made. So it was good. Just want to let you know that had happened.
That.
Okay. Any questions on a claim?
Could you go back to, may have missed the pie chart for the
medical center?
For the medical center.
Oh, okay. The payer mix, yes, I did skip over that with time.
And it's kind of dovetail to what we were talking about earlier. Because when I looked at the managed Medicaid side, it's floating between 13–14%. And the Medicaid side is 8%, but a year ago it was 12%. And a year before that it was 12 or 11% or something like that. And that is almost 33% drop. So that's why I said we need to tighten up the vendor to make sure that they are qualifying, because that is concerned at 8%.
We will definitely look at that. We've also had some shifts in some of the other pie pieces. So when we look at that, we'll make sure to look at the dollars that are coming through and the availability. Pie charts are sometimes they're misleading. I know that we brought on one major commercial plan in the last year that has helped with some of that growth in that pie piece.
Well, did managed Medicaid go up?
No,
over the last
13, 14 for the last 2 years in same period in February, March. But the Medicaid obviously dropping.
Relative to the other mixes.
Relative to other mixes.
Okay, we will look into that, see if there's an issue.
When I look at self-pay and other, they're kind of pretty consistent with that. So, because sometimes you pull self-pay over to the Medicaid bucket because these people will not be into the managed care bucket. They have to go to the regular traditional one. And when I look at that, there is some concern there on the job. And, you know, it's still time for people to calibrate and all that stuff. I just want to point that out so that we can pay more attention to it.
And we will, DT, based on your suggestion, meet with change in med data again and start tracking what percentage of inpatients are not interviewed.
Okay.
Are there any other questions on the financials this month?
All right, thank you very much. We'll move to item 5B. Oh, we have to accept, I'll entertain a motion to accept Ms. Clark's financial report. Motion by Dr. Weber, second by Reverend Emerson. All in favor, please say aye. Opposed? Motion passes. Thank you. Item B, please.
Yes, I'm up for 2 managed care contracts this month. The first one is Magellan Providers. This amendment, if it's approved, would allow their Medicare patients access to our psychiatric services here. We already have a large contract with them for other products. So this is just the addition of Medicare.
Medicare. Okay. Motion by Mr. Petty, second by Mr. Nguyen. Any further questions? All in favor, please say aye. Aye. Opposed? Motion passes. Item C.
This contract amendment is kind of to follow up at the board meeting. If you recall, we approved 3 contracts for Medicaid plans here in Tarrant County. This amendment will reflect the increase for the Europe implementation for Aetna.
Okay, any questions for Sharon on this item?
I'm sorry, what, the implementation of what? I'm sorry.
The Europe, the new taxation program that Tarrant County is under, that allows us to provide IGT dollars to HHSC.
Called UIP.
URIP.
UIP.
Yes.
Not Europe.
Uniform
URIP.
Hospital I lost
That's as far as you
I had
got.
it written down at the board meeting.
Really, uniform
But,
hospital.
rate increase program, I believe.
Because it
Yes,
sounds like
you
you're
wrote.
right. It's a different one, that's why.
Okay, you heard the explanation. I'll entertain a motion.
Move for approval.
Motion by Mr. Nguyen, second by Ms. Debose. All in favor, please say aye. Opposed?
you.
Motion passes. Thank you, Ms. Clark. Robert William.
Good morning.
Good morning, sir.
This is a construction request to add a third MRI to our armamentarium. We have two. In spite of two, we're still running a 6-week backlog on outpatients. Dr. Schrader can attest to the fact that we have some trouble getting folks in. We have a 24 to 48 hour delay sometimes for inpatients, which contributes to the length of stay, obviously. So this is a request for your consideration to award the construction contract to Hutcherson. They were the only one who submitted a bid. We had 5 folks that came to the pre-bid conference. We reviewed all the specs with them, and they're the only ones who submitted a bid for the project, which I think speaks to the difficulty and the complexity of the project itself. So we have a room that has been used for HVAC repositories. It's really convenient adjacent to the MRI that we could raise all of that plumbing and piping and conduit, and it would fit perfectly. It's the perfect size.
Not Mendenhall's server room, is it?
No.
No. Okay, good.
David has blessed that room. We've had several discussions about that. So I'd request your consideration and approval of an award to Hutcherson Construction in the amount of $1,455,730,000.
And this is budgeted? And
This is budgeted.
Okay. Any questions? Okay, we have a motion by Mr. Petty. Second by Dr. Weber. Question
Yes,
by
sir.
Mr. Norris.
What is it that we ask for? I mean, not just the high notes. What is it that we ask for that causes us to not get more than one bidder that's giving us a bid?
Well, like I said, 5 attended the pre-bid, but hospital construction's complex. And when you're in an area of high complex technology, that there are shielding requirements for the floor, the walls, the ceiling, raising all of the conduit, it's not an easy task. It's not a home construction project. So I can't tell you why the other 4 didn't submit bids, but they appeared for the pre-bid conference, and we can only surmise that Hutcherson knows this business. Hutcherson has been doing work for us for a long, long time.
Well, I'm not against Hutchison. I'm just curious. I mean, were these other guys not used to hospital work?
I don't know who they were. So I would assume they had some familiarity. Otherwise, they wouldn't have attended the pre-bid conference.
Right,
and there's certain aspects of hospital construction that are easier than others. Right. So I can't. They didn't tell us why they didn't bid.
Right.
We only have one to present you.
I think one reason is because those contractors are all busy. I mean, they're busy.
They're busy.
I mean, they all have backlogs of work right now. I have a relative in that business, and every time I talk, they're another couple of months behind. And just be able to keep up with medical construction is a challenge right now. So I'm glad we had
The luxury of saying pass on this one.
We're going to take that one instead of this one because it's easier and we can make more money quicker. And it's not always that way, but that's
not
the
always.
environment we're in right now.
What I've found a lot of times when there is a problem with the bid, say if the specs were complicated or maybe problematic from the industry's perspective, is you'll get an input from the non-bidder saying, we didn't bid because of this.
Yeah. We
that
didn't
helps
hear
you
that.
shape your future bids.
Didn't hear that.
I've written those letters.
And also, what Trent said, you'll notice when there's a large number of bidders, is that the work is slow.
Right.
And when the work is plentiful, it narrows the
Nobody
list.
shows, right. Okay, we've had a motion and a second. Any further questions for Bill? All in favor, please say aye. Opposed? Motion passes. Thank you, Bill. Mr. Mendenhall, we were just talking about you.
Thank you.
Item D. No, item E. Sorry.
Good morning.
Morning.
The first proposal that you have in front of you for you is to talk about adding additional storage space to our storage area network. So we use a storage area network here at JPS to store all of our medical images, all of the data coming from Epic, all of our loss and financials. Every piece of data that we have at JPS goes onto our storage area network. And we try to forecast where we're going to be about 36 months out, so we don't have purchases every year that we have to come back to the board to talk about. So it's been 2 years since we've increased our storage area network. Right now we're running right at that 70 to 75% capacity, and that may seem like, well, we have 25% capacity. Well, that's not exactly true, because that 25% capacity is going to run out over the next 8 to 9 months with the run rate that we have with Epic and our medical imaging. So this request is in front of you for $1.5 million in approved capital budget, and then $200,000 in approved OpEx budget.
Any questions for David? Entertain a motion. Motion by Reverend Emerson, second by Dr. Weber. All in favor, please say aye. Aye. Opposed? Motion passes. Thank you, David. Item F.
The next contract that's in front of you is, you have a lot of data, but now you need to back it up, and you need to be able to do something different. And backup technologies over the last 5 years have evolved compared to what we were doing 5 to 10 years ago. So this is a new technology out there from a company called Rubrik. We've been in proof of concept with Rubrik for over a year now, testing out all of their technologies on how they would do with our environment. So now we've passed that test, and many organizations are moving to this new evolved technology with Rubrik. And so this is to move all of our current backup solutions to this new technology. Now, when we went out and did an RFP for this technology, what was really interesting is our incumbent that we currently have on site running our backups was 4 times this amount to continue with the capacity that we currently have, and we project over the next 3 years. So that just comes to show you that the technologies have evolved so much, and systems have gotten a lot more denser, better software, better collaboration with all the technologies, that we're able to do things about 25% the cost of what we were doing it 5 years ago.
Nice.
Is this all on site?
Between our 2 data centers, yes. And the next evolution of Rubrik is to then allow cloud backups as well. So we're going to have 3 of these Rubriks at the JPS data center, which is in our basement here, and 3 of them at our Richardson data center, and they'll be in full replication of each other. And then when we get to a point, probably 2 years from now, we'll be coming back to you guys and saying, now what can we do to the cloud?
Yeah. Is this something that give us the capability of hot swapping, or it has to be restored?
Actually, no, that's a great question. So what this technology allows us to do, okay.
I'll let him put in the right wording.
Yeah. So think about it. You guys probably have thumb drives at home, or ways that you back up some personal data or pictures or anything else like that. Well, we do the same thing here with all the medical information that we do. The technology that we have in place today, if a server goes down, if Epic goes down and we have to do a restore of Epic, or Lawson goes down and we have to restore that, our first thing that we have to do is put hardware in place and then do a hard restore. So we have to move all that data onto that hardware, and there's hours that can elapse during that time. So the last time we did a full system restore, which we test this every month, it can take 12 to 15 hours to restore that system, so that then we can allow users back on it. With this particular technology, what we do is every night we take snapshots of that data and we push it out to the backup system. If the system were to go down, all we do then is now point to that snapshot, and within 30 seconds to 60 seconds, we can have that system back online again with where we were yesterday. Wow. And that's a significant change. I mean, when you think about Epic being down for 12 to 15 hours on a restore, or 60 seconds to be back and available. So thank you for asking that question. That's some of the changes we've been making.
Big difference. Okay. I forgot where we were.
Move for approval.
Second.
First by Mr. Nguyen, a second by Ms. Debose. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you, David.
Good.
Item G, Castleberry and Lake Worth ISD. Ms. Duncan. Dr. Duncan.
Hi, how are you?
There.
You're good.
Good morning. This is an agreement for your consideration to continue our agreement between Tarrant County Hospital District and the Castleberry Independent School District.
Okay. Continuation of what we're already doing.
What we're already doing, yes.
Any questions for Dr. Duncan?
Yes.
When I was looking at this, is that a good rule of thumb, say $250,000 a clinic at a hospital a year? That's what this seems to be. Is that the norm? When I think of a school clinic that we're working with, is that something I can lock in my brain, is to say about $250,000 a year per clinic?
I'm not sure what you're asking me.
What's the question?
I'm just looking at the cost of the system, of the program, right, and the contract, and it says, I was looking a minute ago.
246,680.
Yeah, 246,680. So, I round that to 250 because that's easy. And I'm just wondering, is that a good round number that I can put in my head and say, whenever I see a school-based JPS clinic, I can give or take $250,000. Is that right?
Well,
the average amount that we typically pay for.
So, that would depend on of course, the volume that we would see through that school-based clinic. A lot of that cost is in our immunizations. I mean, that is part of the supply cost that we have, so a large part of that. So the more volume we have, the more immunizations that we're going to be administering. So
I think the question is that a typical amount? Right. I know there's going to be some variations and all, but
I think it is. Historically, that's kind of what we have budgeted when we had a school-based clinic.
Okay.
Yeah.
I just like to lock. I'm a still engineer, and I like to kind of lock a brain something.
Yeah. If we look at volume, it's pretty much even across. So I would.
Just the order of magnitude that you would expect for.
The staffing normally stays about the same because you have
because you have a nurse practitioner, you have an LVN, you have an MA. So
pretty stagnant.
Yeah, the FTE is going to be pretty fixed from site to site.
Right.
So.
Okay, I'm just curious. Thank you.
Yeah.
Oh, good question.
Any further questions? Entertain a motion.
Move approval.
Motion by Ms. Debose, second by Reverend Emerson. All in favor, please say aye.
Aye.
Opposed? Motion passes. Thank you. Ms. Whelan. Morning, Kathleen.
Today I'm bringing forward two contracts. The first is with Massimo Americas, and this is a contract that's approximately $1.3 million a year. Over a 5-year term, it would be $6.5 million, and it's for consumable pulse oximeters. So I brought you a sample. Want to bring show and tell. These are the pulse oxes that are placed on all of our patients for vital monitoring for oxygen saturation. So we use about 175,000 of these units a year. This contract actually reduces the price from a per unit cost of $965 to $750 per unit for the first 3 years, and then the second or the fourth and fifth years, it will be based on the medical care CPI index at a maximum of 3%. So I'm asking for approval today for the Massimo contract.
Okay.
Yes.
People come running in. That's what you do. Yeah, those are important. And are those like one and done? Or we use them for, or are they?
They're 175,000 of these a year.
Wow.
Each individual.
Is that a smart cable or is it still the old serial cable type thing? RS-232.
That is a technical question that I'll have to get back with you on.
my curiosity is around the cable. Sometimes it's loose, so you have to have a false alarm, so the nurse have to jump in.
Correct. David, thank you. That's why I brought it, so I knew David.
Yeah, this is a DB8 or DB9 serial connection. So
I was gonna say that, but
I brought my
didn't want to show
resident
off.
expert.
Thank you, Steve. I was
Yeah.
too.
Do they have smart cables?
They do not.
They do not.
For those technologies, they've still been using the serial cables they've been using them for years. And the snap-ons, the biggest thing is the snap-on on the inside, and this has a magnet on the inside, so it does snap, so it does take a pull to be able to do that. So the newer ones are going to be, or the next generation ones that are going to be coming out, do you use the RJ11 technologies and RJ45 technologies that we would see like on an Ethernet connection, but those are having just as many breaks as these. So I think this is probably going to be what we're going to be using from now on.
Oh, I see.
So.
Kathleen,
Yes, sir.
is this a new contract, or is this a new company, or this a company we used before?
This is a company we're currently using, and this goes with the actual monitors that we already have purchased and in place and have had for at least
The
5
hardware,
years.
yeah, and that's the industry leader.
Yeah, this is an
Massimo's.
industry leader.
So we were able to get it dropped roughly $2 because we did a 5-year, or how do we?
Actually, it's due to a lot of the negotiation that our material management supply chain team put in place with us and negotiated this price with us. They did a lot of hard work on this.
They did a lot of hard work.
Yes, they did.
$2.
Yeah. Okay, you've heard the description. Any more questions for Kathleen? I'll entertain a motion.
So moved.
A motion by Reverend Emerson, a second by Dr. Weber. All in favor, please say aye.
Aye.
Opposed? Motion passes. Item I.
Our next item is for Abbott Laboratories. You may have seen in your book, it's actually called St. Jude, or noticed as St. Jude. St. Jude was purchased by Abbott in 2017, so it's a transition period for that product. These are a series of products that we use in the invasive lab, which we talked about earlier. It's the implantables such as the carotid, vascular, peripheral stents, renal stents, and so forth, the IVC filters, guide wires, catheters, and balloons. It's a very big mix of supplies that we use. It's just over $1 million a year, and this is a 3-year term coming in at just over $3 million a year. We are not seeing an increase in price, but neither did we get a reduction in price, but we're going to hold for at least 3 years on this. Okay. And these are supplies that we use every day for all the procedures that we do in that area.
In budget.
Within budget, yes, and asking for approval today.
Motion by Dr. Weber, second by Ms. Debose. Any questions for Kathleen? All in favor, please say aye. Aye. Opposed? Motion passes. Thank you very much. Counselor, anything in the...
Yeah, there were, for the month of February, there were 22 contracts negotiated that were under $200,000, and one contract that was between $200,000 and $500,000, and those are on the report that's on the portal.
Okay. Any questions for council? And we have nothing enclosed, so therefore we are adjourned. Thank you.
So Neil did the NC2A tournament?